Okay, so this is Nursing Care of the Newborn and Family, Chapter 23. So birth through the first 2 hours of life is at stage 4. It's usually done on the labor and delivery floor before they're transferred to the postpartum unit. Immediately care begins. We're trying to look for risk factors from birth and how that might affect the baby. And the primary goal is to get that newborn into transition into new life. This is where your full exam is going to be done. You're going to be really monitoring the effectiveness of respirations, looking for problems with breathing. Helping that mom get a latch in that first 30 minutes is also important. So the initial assessment is you need to know how to do that. That's what you practice in lab day. There's a table 23.3 to look over and know that well, especially before going into clinical. And we'll talk about what APGAR scoring is in a minute. Basically, that's what we grade the baby on at 1 minute and 5 minutes based on some of their vital signs and other things. All right, so birth through the first 2 hours of life, again, we're looking general appearance, vital signs. We get a weight, a head circumference, a body length. We're doing a neurological assessment, checking those reflexes. This is a chart showing you newborn or neonatal resuscitation, or NRP. So neonatal resuscitation is way different than CPR for the human because this is based on that baby's transitioning into life outside of the uterus. So it's really fast. If you work in this field, you will know this very well. We will be going over this in our next lab day. There's a couple videos of this in your content sheet for this week that you should definitely watch. So basically it's every 30 seconds we're deciding what to do next. So first we ask, is the baby breathing and crying, and does it have good tone? If the answer is yes, then just warm it or just dry it, clear the airway, and put it with mom. Skin to skin is the best. If no, then we need to warm the baby, dry off all the wetness, clear the airway, so bulb suction the airway, and then kind of stimulate it, rub its back really hard, flick its feet. And then if it's still not crying or breathing, we check a heart rate. And if the heart rate is below 100, then we start positive pressure ventilation. The number one thing that helps all newborns transition into extrauterine life that needs resuscitation, that's going to make all the difference in the world, is this positive pressure ventilation. We don't even worry about chest compressions until later because we just want to see if we can open those lungs up, get them breathing and crying, and then our heart rate will go up, etc. So if after another 30 seconds of positive pressure ventilation, that heart rate goes below 100, now we're going to talk about doing some chest compressions, putting an airway in, etc. So we want to make sure that our ventilation is working. We want to make sure air's going in the lungs, and then we'll make a decision whether to start chest compressions. If the heart rate goes below 60, we start chest compressions, and then we're thinking about through this whole process, when are we going to try to intubate, etc. So if the heart rate goes below 50, we start chest compressions, and then there's another 30 seconds and it's still below 60, we're probably going to give some IV ephedrine, either IV if we have the umbilical line established. So we're not starting an IV, we're starting a line in their umbilical cord. And if not, then we can actually send ephedrine, or epinephrine, sorry, not ephedrine, epinephrine down the ET tube. So we'll go over this. I think of note is to look at our targeted SpO2 ranges. So we don't need 100% SpO2. Really, if we're doing a resuscitation the first minute or two, it's between 60 and 70%, and that's perfectly fine. So this kind of shows you how we increase them over 10 minutes to more of a normal range. APGARs are done at 1 and 5 minutes. APGARs are 5 things we assess. They get a 0, 1, or 2. Heart rate, respiratory rate or effort, and muscle tone. Flex, like how flexed they are. Your flex or reflex irritability is, are they crying? Do they grimace? Are there kind of no response? And then the color. A lot of babies get points off for color. It's not a big deal. So it's not uncommon to see APGARs of 8 or 9 at 1 and 5 minutes, but APGAR scores aren't necessarily telling us we need to resuscitate a baby. It just kind of gives us a picture of what that baby was like at that time post-birth. We use that to kind of base some other decisions or get an idea of how they're doing, but does not base the decision of resuscitation. That is sheerly based on, is that baby breathing and what is the heart rate? Next, we're going to talk about doing a gestational age assessment. So this mom just delivered. She's supposed to be 39 weeks. Does that baby look 39 weeks? Or does it look much more premature or more post-term than that? So there's some ways we kind of do that to get an idea of maybe our due date was off type of thing. Especially for women who haven't had early ultrasounds or good prenatal care, this is really important to do. And then we classify the newborn's gestational age and birth weight. So was that weight essentially normal for their gestational age? So here's that gestational maturity rating scale. We're looking at things like their posture and grading posture. We look at what's called the square window. Are their wrists, is their wrist nice and flexed? Or is it kind of just hanging out there floppy? Arm recoil, if we strain out their arm, do they recoil it all back up? Same thing with popliteal angle, which is their knees. Is it nice and flexed, or is it straight and over their head? Scarf sign and heel to ear sign. So again, is the heel touching their ear, or is it the leg nice and flexed like a newborn baby? So they get points on this, and then this helps us with their maturity rating scale. There's also a physical maturity thing. So what's their skin look like? Is there any peeling? Is there cracking? Is it smooth and pink? Is it sticky? Like they're really premature, it's sticky and transparent. Lanugo, that hair, is there none? Is there a lot of it? Is there just tons and tons of it? It kind of goes up that way. Plantar surface, breast is tissue area. What does that areola look like? Eyes, are the lids fused? Are they slightly open or slit open, or is it normal baby eyes? Genitals, again, too, scrotum's flat and smooth, and then it gets the rugae, and then the testicles drop. Same thing with the female genitals. The labia is nice and flat, but then more mature labia and minora are kind of bulging out a little bit. So we got to look at the baby, kind of give them an estimate of what their gestational age is based on their score. This is looking at weight. So again, these weight charts are going to be by gestational age. So on one side, we look at how much the baby weighs, and then we look at how many weeks they were, and then was it small for gestational age, appropriate size for gestational age, or large for gestational age. Immediate interventions, again, we talked about drying that baby off with some towels or baby blankets when it's first born so they don't lose heat. And then looking at the airway, we use a bulb syringe for that. And if you've never used one, we'll have some in lab for you to practice. We want them to maintain good oxygen and temperature, and then we give them some medicine. So we give erythromycin in the eye. It's a gel, and that's to prevent blindness from gonorrhea. And we don't even ask questions. We just give that to all babies. There was, back in the day before we did this years and years ago, a lot of blindness caused by that. So every baby gets that, and baby gets a vitamin K injection. Vitamin K is used to help baby be able to clot when you're born. They don't have the microbiome in their gut bacteria that helps to form clotting factors. And so the vitamin K helps that until they start feeding and grow that microbiome. And then again, promoting bonding behaviors between the parent and the baby. So this is just showing you some of the assessments, weighing them, getting their length, getting a head circumference, seeing how their eyes are set according to their ears, or how their ears are set. So are they in line? This is a low set ear, which sometimes you see in things like can be normal, but this is definitely low set, which you might see in something like Down syndrome. Looking for birth injuries. So this is a picture of a baby with face presentation a couple days later. You know how I said they look pretty bad? I'm guessing this baby, when it came out, was extraordinarily swollen. Like you couldn't even see the eyes. And then all of that swelling has gone down, but it's very bruised. So we're looking for birth injuries. We put, if you did a C-section, is there any lacerations where we might have cut the baby, etc.? And then we will also check their glucose if we need to, and think about phototherapy if they come out, if they had some, especially babies with RH incompatibilities, or maybe mom bled out, there's an abruption, etc. Okay. Sometimes we need urine specimens from those babies, especially if we're looking for drug screening. So we'll either put a sticky bag on them, or a gauze pad, which soaks up the urine, and then they can send that in. We do some universal screenings of the newborns. So this is a heel poke usually, and it's little spots, little round circles on this special paper, and we got to fill the circles with blood. And then that goes off to the state lab, where they look for things like PKU and some other newborn diseases that, if we catch them early, can be life-changing for that baby. So we do that on all the babies. We do a newborn hearing screen, and we usually get a blood sample for that 24-hour bilirubin. We'll check for congenital heart disease by checking the blood pressure and the O2 sats on opposite limbs and documenting them. So it's just some things that you'll see the nurses do. There's usually a nurse in Muskegon she's the normal newborn nurse for the day, which means her job is to grab all these babies who need their testing and screening done, and one by one get that all done. So again, from 2 hours until birth, we're looking at protective environments, infection control. We don't want the babies to be abducted. There is usually always someone, that's a picture of someone that has been seen walking the labor and delivery halls that shouldn't be there, that we're really concerned with abducting babies. There are a lot of people with some severe schizophrenia and some other psychological things that part of their delusions and hallucinations are that their baby's on that unit, or they want a baby, etc. So we do have to be careful of that. That's why we put these security bands on them. That's why when we take a baby to the nursery and bring it back to mom, we're checking to make sure mom and baby's bands match, etc. This also is a period of time where we're teaching them safe sleep, how to be safe at home when they take the baby home, and things like that. So we're going to talk about circumcision here in a second, but again, we might, other than the vitamin K and the erythromycin in the eyes, we usually give them that first Hep B vaccination when they're born, and that's all intermuscular. And so if it's a male and the parents choose to do circumcision, there's a couple ways that this is done, and one is called the Gomco, and the other one's called a Plastibell, or a Circuplast. Circumcision is not needed. It's not medically needed. When an AIDS epidemic happened in the 80s, circumcision became super popular as a prevention for HIV. In industrialized nations, circumcision doesn't really show a difference in HIV acquisition or not. There's actually a lot of benefits to not circumcising the baby. The penis with foreskin tends to be more sensitive and have higher sexual pleasure. There is a kind of an old wives' tale that we circumcise our babies so they're clean. It's really not that hard to teach little boys and to pull back their foreskin and clean underneath it, but and there's not a terrible increase in industrialized nations of infections due to having a foreskin. So it's kind of it's not a needed procedure. There are some religions, like the Jewish population, who do that, but they don't do it in the hospital. They have ceremonies for that, etc. So there's reasons why people would and wouldn't, but if people don't know, we have to educate them, be able to tell them that there's really no need for it, and these are the risks and benefits. There is, well, here I'll tell you, this first picture is this kind of archaic looking device. This is the Gomco, and that's the little baby's penis, and it's going to chop off some of the skin there. These are the Plastibells that they can put on and then tie off the foreskin from there. I have inserted 2 videos on how those are done so you can see them. And I'll try to get as many people in to see one in labor and delivery postpartum when you're there, but it really just depends on if there's going to be any or not. We do a neonatal pain assessment. We use the NIPS scale, but there's a couple different neonatal pain scales out there. And then kind of how we manage that is next. So the NIPS scale looks like this. We score them based on their facial expression, their cry, their breathing pattern, their arms, their legs, and their state of arousal. Here's another scale called the NPAS, and I'll have you take a look at that on your own time. We use the NIPS scale in Muskegon, so you will be documenting on that. Again, so the whole entire 2 hours until discharge time is the time where the nurses are helping the mom and the baby transition into life, bond, and then a ton of education. So we're teaching them about feeding patterns, elimination, safe sleeping, car seats, immunizations, diaper rashes, how to breastfeed, how to bottle feed, how to burp, all those things a lot of people need instructions on. We want to make sure that the parents have clothing for the baby, that they have a car seat, they have the things in place, they have running water at home, they have support systems that they need. If they're without formula feeding, do they have access to buy formula or to WIC? Teaching them how to bathe an infant and umbilical cord care. You don't submerge that baby into water until that cord comes off, and so we got to be sure they know that. We don't want that to get infected, so it's sponge baths only until then. Infant follow-up care is important, so making sure they have that pediatrician appointment made before they leave the hospital. And usually peds around here like to follow up in a couple days just to make sure that baby's not losing weight and is feeding okay and they're safe. That might mean that maternal infant health services, well, some of you will get to do that, and your peds rotation goes out to the house and checks on them, etc. So, and teaching the family signs and symptoms of things that are going wrong. So signs and symptoms of illness, signs and symptoms of respiratory distress. If you can't wake your baby up, or your baby's really sluggish, please call or take them into the ER type of thing. So there's a lot of teaching involved in this. So the question is, the nurse administers vitamin K to a newborn for what reason? Mothers have a high diet deficiency of vitamin K, which leads to the baby being deficient. Vitamin K prevents the synthesis of prothrombin in the liver and must be given by injection. Bacteria that synthesizes vitamin K are not present in the newborn's intestinal tract, and the supply of vitamin K is inadequate for at least 3 to 4 months, and the newborn must be supplemented. And the answer is C. All right, that's it for this chapter.